Today's guest is Dr. Amanda Olson, a leading expert in pelvic health physical therapy, also an educator and an innovator. As president of Intimate Rose, she's developed groundbreaking tools, amazing tools that I use all the time to support people dealing with pelvic pain, incontinence, and recovery from a various number of pelvic health conditions. And in this episode, Dr. Olson shares insights on empowering patients through breaking the stigma around pelvic health, through education, and through creating lasting solutions for pain management. Let's get started. Hi, everyone, and welcome back. I have an incredible guest with me here today because, and if you're not watching YouTube, I'm like putting my fingers in the air right now, because of a couple of things. One, she is not just a clinician. Two, she is a she, and I think that's important when you're a clinician. And number three, she is a clinician and an entrepreneur. So three fantastic things. Welcome, Dr. Amanda Olson.
Thank you so much for having me.
Yeah. Thank you for taking the time out of your crazy schedule, because I get your emails and I know you're like popping around to all these conferences, and I know that I'll see you in a couple of weeks at another conference and then again in March, and it's going to be fantastic. So I am really excited to have you on the show today because you're truly an inspiration for a lot of people. If it's not because they're a patient and of pelvic health and they know how amazing you are, or you're an inspiration because you're an entrepreneur, or because you're doing all this stuff and you're also a mom, and you're just, forging a path, which is fantastic. So for those of you guys who do not know Dr. Olson, I want to introduce her to you first. She has a doctorate in PT, physical therapy from Regis University, and certifications, various certifications. My eyebrows go woo in pelvic floor therapy, stop Pilates, running coaching. She's also president and chief clinical officer of Intimate Rose, where she develops pelvic health products and education. She's very passionate about empowering individuals with pelvic health issues, and she specializes in pelvic pain, incontinence, pregnancy, and postpartum care. She's an international lecturer on pelvic health and has authored articles and the book, Restoring the Pelvic Floor for Women. Welcome, Amanda.
Thank you so much for having me.
Yeah. All right. So I want you to take this phrase on and run with it. It's all in your head. So, everybody take a breath.
It's all in your head can often be delivered in other phrases, and that would include imaging's clear, not really sure what to tell you. Have you tried having a glass of wine? Mm-hmm. Here's what other people who have anxiety have benefited from. Have you tried a counselor? And these
my heart
things,
rate's rising.
Yes, these are so triggering. Perhaps you've heard it. My heart rate goes up too.
Yeah.
And additionally, I get that feeling every time a patient comes into my office and says that that's what they've heard, because it continues to happen. It is getting better. But to unpack it, imaging's clear. I'm not sure what to tell you. Well, there's a lot of things, including musculoskeletal drivers of pain and visceral drivers of pain and inflammatory drivers of pain that don't appear on imaging. Whole disease process known as endometriosis is not visible on imaging. There's certainly some new introductions of different types of technology and AI where there's hope that might be able to pick some things up coming down the pike, and it may not always be this way. And perhaps if we're listening to this episode in 10 years, that will have changed. But all that's to say is you can have clean imaging and have a true and legitimate musculoskeletal driver of pain.
So additionally, can you repeat that again? Just like that bears repeating.
Sure. So you can have clean imaging and have something like a trigger point or a tender point or a muscular imbalance that can be driving pain that is a legitimate musculoskeletal, and I'll add that I didn't say previously, fixable
Oh, yeah.
condition that isn't going to appear on imaging. So depending on who your care team is, that the fact that we've started with a symptom like pain or bloating or other issues, and we image and there's nothing there, it begs the question, who else should this patient see to be evaluated to determine what's causing the pain? Because you're not nuts. You're
Yeah.
you're you're experiencing something, and it warrants follow up. Um, and the brain is involved in terms of the pain experience. We have a brain that perceives things from different parts of our body. And the longer we have pain, that can change. Our system can become more sensitive to where maybe something's not necessarily um, an actual tissue damage or a tissue injury, but it's starting to feel that way. But all of that still requires working with the muscles and the nerves and the tendons and the brain together to retrain certain patterns. So all that's to say is where it's not in your head, your brain is involved in the healing process. And in rehabilitation world, pelvic health, physical therapy, and occupational therapy, we want to work together with your multidisciplinary team to do an actual evaluation on your body and determine if there's something happening within the pelvic floor or the hip or the low back that is the driver of the pain. And then we're going to help work with you to create a plan of care so that you can move on and reach your goals and live a life not encumbered by pain.
Yeah. I think that's one of the most hopeful messages. If someone says, "Oh, what does pelvic floor PT really do before endometriosis excision or in absence of excision?" Maybe someone has had ablation, or maybe post-op excision when they finally do have that surgery. One of the most hopeful things that pelvic floor PT brings is that we're not going to ignore those unexplained symptoms. And before we started, we hit the record button, Amanda, you were saying something that I think also needs to be repeated, in that unexplained symptoms deserve investigation. And that's the hope that pelvic floor PT brings, because we're not going to ignore those symptoms. Whereas, the other problem with endometriosis is pain can be very cyclical and it may not follow a particular pattern. And that is where I think women are chronically, like, epidemically misdiagnosed with mental health issues. Yes, pain is perceived in our head. So it is in our head, but it's not a mental health issue in our head, unless you end up suffering a mental health issue as a result of the crappy care that you got.
I was just going to say that it becomes a mental health issue
Yeah.
out of fatigue and exhaustion and
Right.
gaslighting to the point where you no longer trust your own instincts or trust what
Right.
your own body is trying to tell you.
Yeah, you've been medically gaslit to the point where the system has traumatized you,
Yeah.
basically. And still, then, even if you have, that mental health issue, um, dang it, it's the system's fault. It's like an institutional betrayal that they didn't take care of you, and then they just kept gaslighting you until you had that issue. But talk to me a little bit more about the unexplained symptoms, because there's such a wide range in endometriosis that can be cyclical, that can follow no particular pattern, et cetera.
Absolutely. Goodness, where to begin? I think about, digestive issues and how it's often the first presenting feature before
Mm-hmm.
one even starts their period. I lived that as a person with endometriosis. Gastrointestinal issues were my earliest medical
Yeah.
memory.
Yeah.
um,
Me
and
too.
then, yeah, yeah.
Mm-hmm.
I
Yeah.
think I read something like that is the primary for most people once they understand it better. Um, I think about pain radiating down the thighs and up and
Mm-hmm.
into the abdomen, tailbone pain, which we'll talk
Mm-hmm.
more about. Um, Deep pain that can't reach it, can't stretch it. which we on the pelvic health physical therapy side know can be driven by restrictions in deep pelvic floor musculature that we can reach
Yeah.
internally in a very gentle manner. And then, different issues cognitively with cognitive fog and certain headache type related issues that can be associated with
Yeah.
hormones and inflammatory responses as a byproduct of living with the disease.
I have a lot of patients, and when I remember when I woke up from my excision surgery, my hands were already on my body doing orofacial release, like involuntarily. When I woke up, I was already doing that, that manual therapy. But to get to the point, I have a lot of patients who have orofacial pain because you mentioned headaches. And I think that with the disease being, estrogen mitigated or mediated or driven, whatever word you want to choose, that you could validly have those headaches. But I think a lot of it can genuinely be orofacial pain from, maybe it's from the medical gaslighting. Like, where are you holding stress, right?
Yeah.
Do you clench? Do you grind? Are you having nightmares about it? Are you waking up in the middle of the night, in some weird protective trauma posture? In addition to the things that the, estrogen or inflammation can drive.
Absolutely.
Yeah. So what are some other red flags that we mentioned? The gastrointestinal, and for you and me both, that was a red flag in the beginning that was entirely ignored. I was handily gaslit over that for a lot of years, with gastroenterologists, gynecologists, everybody, essentially, even well-meaning colleagues, that didn't understand. But what are some other red flags? Do we leave any other red flags out in patient history that often point to undiagnosed endometriosis, or make it such that endo should be on the list of things to rule out?
I would say pain with tampon, speculum, or penetrative intercourse, or
Mm-hmm.
pain with climax during intimacy. Oftentimes, that tampon feature can be early and presenting, when first onset of menses, or sometimes it's later on in life, but just pain, pelvic pain associated with something coming inside. And that can be due to adhesions in the viscera and muscles themselves. And it can be because of that guarding reflex that you just spoke about with the headache and the
Yeah.
clenching in the jaw, but the pelvic floor muscles providing that guarding response to try to be involuntarily protective, but that leads the muscles really tight, just the same way as clenching and elevating the shoulders does.
Mm-hmm. Yeah, I've actually seen, had a really good example lately on imaging, where I was imaging someone, their pelvic floor, ultrasound imaging, and we started to talk about a rather large stressful event that was about to happen. And her pelvic floor, she had no idea it was happening. That was a turning point in rehab for her. The pelvic floor, immediately when she began to talk about it, it just kept coming up. The bladder base just kept coming up, coming up. So the tension in the pelvic floor, it just kept rising. And it wasn't just a little, it wasn't a few millimeters. It was like 12 to 14 millimeters. It was like a pelvic floor full contraction. And I stopped and I said, "Did you just feel that?" It was kind of like if an earthquake just happened, I stopped. I said, "Did you feel that just happen?" She was like, "What?" I have some pelvic pain. What's happening? I said, "Okay, let's do some breathing. Let's talk it back down." And then in the image, the pelvic floor came back down again. But a few minutes later, I was like, let's just make sure that's not a fluke. Let's see if this is truly a driver, if this trauma that you are about to experience, that you cannot get out of, that you don't want to have happen, but it's going to happen. Just start talking about it again. And it went right back up again. And it was just a consistent trigger for her. And it was just verbalizing that stressor. That's all it took. And the pelvic floor was like, fine, we're out. We're doing what we want. And it kind of went offline and she had no control over it.
I have had that experience with a patient as well. It's so incredibly interesting. I had just placed my index finger in for assessment. It wasn't
Mm.
first eval, but it was just, I had literally just gotten in there, and she recounted the death of her husband. I
Oh,
in 16 years of being a pelvic health PT, I've not had this situation where my circulation was cut off on my finger. She went from normal
wow.
baseline neutral
Yeah.
pelvic floor tone to clenching so hard that I wasn't worried about myself, but I was in pain. It was
Yeah.
cutting off my circulation on my finger, and I'm listening to this poor woman recount the death of her husband and seeing
Wow.
this very clear
Yeah.
trauma response of her pelvic floor. And it was the exact same thing. She had I said, "Are you able to feel the tension in your
Yeah.
pelvic floor right now?" And
Couldn't
no,
feel it.
no cognitive knowledge of
Yeah.
this motor behavior of her body.
And that's how that is such an important point, because if you are, no one has the exact skill set that a pelvic floor PT or OT is going to have, like no one. And so no one can evaluate you. If you're listening, no one can evaluate you and then just tell you that, oh, you absolutely 100% need pelvic floor PT, because we're the ones that evaluate and determine whether or not you need it. And it's why I feel so strongly, I think, that everyone with a diagnosis of endometriosis, because of the trauma and everything, even if you haven't had surgery, or if surgery, you can't do it or can't access it, I think 100% of women need to be evaluated because of things like this.
Yeah.
So that just, it's, I just have to take it like a full breath, thinking about these women, these cases that we're talking about that are real people that have been in our recent, clinical practice history. I know it affects me. I know it affects you personally. It's not just another case. So I think if we can just like impress upon you as a listener that that's the degree of passion and how strongly we feel about women having access to this care. And I think that, and I believe that, and knowing you, Amanda, and knowing what I know about you as a colleague and as a friend, is that deep passion is what drove you to create what you did with Intimate Rose.
Yeah.
And that is all about innovation. It's passion, but then it's a lot of blood, sweat, and tears. It's probably, it's a lot of loving what you do and then hating the tedium of what happens on the other side of it. It's so hard as a female to be an entrepreneur anyway, and then to do that as a mom and to do it with all of the barriers that we have, is just incredible. So first, like, thank you for doing what you did with creating Intimate Rose and all of these pelvic health tools. And I have a little toy box at work, and it's on roll. It's everything I like to be on, like wheels and roll around. So I have my rolling pelvic health toy box, and it's full of your stuff. And so I just want to talk for a minute, about that little bit of that backstory. Now, Amanda's been on the show before, so if you haven't heard her story, you've got to go listen to it. So go and look it up. It's in a previous season, and listen to that so you can hear her backstory and history. But I'd like to hear you talk about those pelvic health tools and your, passion for doing this as, um, a a catalyst for and reason for empowerment, for women. And I think that word gets overused a lot, but maybe it's because we're not truly, like, I don't think we've reached the level of empowerment in women's health that we can aspire to yet. So tell me where that comes from you in creating, the line of tools and supplies and all that, and how it fits into empowerment.
Absolutely. I think at its core, I wanted to make things that looked pretty and hopeful and cheerful, and
Y'all, they are. They're
they
very pretty.
thank you. They're bright and they're cheerful and destigmatized, and recognizing, and I think all of us in pelvic health therapy feel this way, is that we want to help you feel better as fast as possible, but a lot of these things require new habits and new changes that do take time, and they take a lot of practice. And our sessions, we're always bringing, as much education and manual therapy and care and love into our sessions as possible, but it's not enough, and it has to carry over into the lifestyle. I mean, I know you've heard it, Ginger, and I hear it all the time is, oh, it feels so good when you relieve that tender point. Can I just carry it around in my pocket? Can you, can you come fix my constipation at home every day? Because
Yeah.
I feel great after our sessions. And then, I go home and I go back to life and things go back. And so the tools are all intended for home use, for people to take control of their symptoms and be making gains towards their goals, and also managing their pain and their symptoms independently so that they can feel better faster, reach those goals faster. And because at some point you're going to graduate and you are going to live a life without appointments, which is the whole point, is
Mhm.
not that we never want to see you again, but we want you to go live your life. And
Yeah.
flare-ups can sometimes happen when we experience a change in our health status, or something stressful happens. And it's meant as a means for you to say, okay, it's another one of those. I know what to do. I'm going to use my wand. This will all be better in a few days, or this will all be better in 20 minutes when I just get the wand in there
Sometimes it can be.
and get it done. So yes, there is a means to empower people to have the knowledge that we're giving them, and also to be able to reach and really truly make changes in their body to feel better.
Yeah. So tell me about, pick one or two tools. Pick the ones that you think are the most beneficial for women with endometriosis, across the spectrum. Now, we're both, women with endometriosis,
Yeah.
so we have all kinds of stories.
Yeah.
But share a little bit with me about that, because I think that, the listener may have never even picked up or seen one of the tools before. So,
Yeah.
yay!
Bring
If
them
you're
up for
watching,
those that are watching on the
yeah, if you're
YouTube.
watching YouTube, then here they are.
Mhm. Um,
And dilators. Yeah. So explain a
yes.
little bit about those, because even now, like, I'll have a patient come in, sit down, and we'll talk about, therapy tools and ways they can take this at home. And of course, I pull things out. And if you've had endo with like painful penetration or painful bladder or any of those things, I can visibly see women go, where am I going to put that? Like,
Right.
they're so afraid of touch and being touched. And maybe they've not had that experience of someone compassionately talking them through how that touch looks and when they're doing it themselves. Take the listener through that and that experience, for just pick an issue with endometriosis.
Sure. And predominantly overarching sensation of pain coming into the pelvic floor that may be prohibiting penetration, whether it's using a tampon or the speculum or intercourse. And that's where the dilators are helpful. And then myofascial pain that feels like you mentioned, pain in the face or the headache sensation or shoulders. And that's where a wand is helpful. So they do go inside the body, but we warm up into it. So starting first, we'll start with the wand. It's the same thing as those nice little canes where if you
This,
have a
yeah.
knot in your neck or your back and you push on it and it's like, oh, there's a knot there, and it's zinging up and over your head and driving that headache type sensation. And you reach back there, you use one of those handy little canes and you kind of rub it and you kind of knead it and you move around. And after a few minutes, oh, that's feeling much better. I can move, maybe I'm hearing better, all of these interesting sensations that come through. The pelvic wand is intended to allow people to do that same thing with tender points, or trigger points as they were formerly known as, or myofascial restrictions in scar tissue in the pelvic floor muscles that can be reached through the vaginal opening or the rectal opening, which sounds very scary. That can be a method used after you've been seeing a pelvic health PT and had some more education, or a pelvic health OT. But Essentially, what it is there's these two little ends and they have different curvatures that just allow you to come inside and gently massage the muscles. And if you find a little tender point, you can just hold this pressure. I liken it to a tomato, whereas if you're going to check a tomato for ripeness, you're going to give it a little squeeze and see if it's ripe and see if it's ready to use. You're not squishing it. You're not going to squash your tomato. Likewise with your muscles. It's just nice and gentle, and you can massage them out, and that oftentimes releases those strange deep, can't reach it, can't stretch it, tailbone,
Mm-hmm.
sometimes even bladder type pain because of those restrictions coming around the muscles. It's oftentimes referral of these tender points can be up to a foot away in different directions. So sometimes you find just by relieving one little tender point, suddenly that front thigh pain that was going all the way down to your knee is suddenly significantly reduced or gone. So that's the role of the wand. I've made different types of wands. They're all the same shape and size, but they have different functionality. So the vibrating wand has been really helpful for people with endo. It's very soothing. There's 10 frequencies of vibration. People can select and use that to help soothe the muscles, get some good blood flow to the area, and make the muscles more relaxed, more flexible, which just makes us move easier and often reduces that chronic pain sensation. And the vibrating wand's been a game changer for a lot of
Yeah.
those people.
Huge fan. I'm a huge fan of the vibrating wand. And just as a side note, for my patients who have orofacial pain that is connected to the pelvic floor, like you and I were describing, I will use the vibration on particular muscles in the orofacial area. So thanks for making that, because it works from the voice to the pelvic floor.
Absolutely. It's so interesting. In one of my previous clinical settings, I worked with some really renowned TMJ specialists. So we had like
Mm-hmm.
me doing pelvic floor and these people
Yeah.
attending dental conferences. And I was at a big conference one time that was open to all the different types of providers. And a very well-known TMJ specialist came up and told me, I know what you invented this for, but I'm having people do it in the mouth and on the jaw,
Yeah.
and it's
Yeah.
making a big change for them. So thank you. And
Yeah.
I think that's fantastic. That's great.
Yeah. Yeah. It is. It is. It is. So, oh, I interrupted you right in the middle of your going over the different types of wands. So
Oh,
I know you also have a new one that's the longer one.
yeah. It is,
Yeah.
for those who are not able to see, it features the same different types of points on either end, but it's extra long and it's bendable. So that allows people to change it to accommodate their own different unique needs. For people who need a little extra reach or a little extra help, making it form to their unique body. The bendable wand has been a really big crowd pleaser for that.
Yeah. I love showing people that one.
It's cheerful.
Um,
It's orange.
it is. It's cheerful. It's orange. And because I have had patients where they're trying to use that internally and they're getting like, it's almost like they need they need a half inch more, length or shape and a different. And so if they need it, now they have it. So
Yeah.
I think that one's great.
Perfect. Love that.
Yeah. And then you've got one that you can heat.
Yes, the
Yeah.
temperature therapy one is actually endometriosis yellow, in
Oh,
homage to endo. It can be placed in the freezer, which sounds to some really jarring, but there's a lot of people that have this just burning sensation associated with their inflammatory cycles, to where that cold feels really good to them. So they can place it in the freezer. It will retain cold and they can do their myofascial release that way, or they can place it in hot water and it will retain warmth and they can do myofascial release with it warm. I'm a warm person, but I have
yeah.
many patients that are telling me they're freezing a glove, they're freezing
Oh
a
gosh.
spoon and sticking that in there. So, in lieu of
Yeah.
those items, may I suggest a wand?
The Indo yellow their wand.
Yes.
Fantastic.
Yes.
That's good. Um, it just goes to show you and underscore that there's so many. I mean, if there's so many different types of wands, and there's so many different types of uses that you get the best result out of it. You can certainly just order them direct. But if you had some visits, with the pelvic floor PT or OT, they would be able to really specifically show you where it is. Because we have models and 3D models and one-dimensional models, and if you use imaging, um, then you're able to get biofeedback in real time of what's going on. So just so many different tools, and I say that because it it's hope that there are so many different things that can be done, and that's just talking about releasing tender points in the pelvic floor, right? Or maybe some around the orofacial area. And there's so much more that it encompasses the multidisciplinary care, that really treating endometriosis is kind of requires.
Yeah.
It's not really optional just to see your excision surgeon and a pelvic floor PT. I think that there's more people, that you could have on your team if you have access to it. So, I mean, let's talk about that a little bit, because there's such a massive psychological impact of endo. Um, where do you find it's been helpful along the way? Like, what other team members do you find as a clinician, as a person that cares about others with endo, and, as a person with endo?
Absolutely. I love having a dietitian available to help patients understand what their unique true allergies and sensitivities are. There's some commonalities that I think a lot of us share, but it's really nice to have somebody that can take a really solid look at you and your life and your day to day, because sometimes I think we look at maybe like an influencer person on Instagram that's saying like these very broad statements that do encompass a lot of people, but maybe not for one particular person. And if they're latching on to these ideas of sensitivities and they don't know how to prepare food that does work, it can feel very overwhelming to
Yeah.
look at all of these different sensitivities and say, well, what am I supposed to eat and how am I supposed to feed the other people in my house?
Yeah.
Based off
That's
of
a
these,
real problem.
um, you know, that can be really helpful. And then under the category of like mental health, there's so many different types of counselors and therapists with different backgrounds. So for
Mhm.
example, like there are licensed clinical social workers who also specialize in counseling that have really extensive trauma therapy backgrounds. I love that. And I've talked to a lot of them and they're so passionate about what they do. And they do a really good job of looking at the whole environment of the person, from
Mhm.
their work environment to their family and how they were raised and all of those things. That's just really incredible. And then there's counselors and therapists who specialize in cognitive behavioral therapy, where they're like really trying to help the person rewire their behavior. EMDR,
Oh, yeah.
it's eye movement therapy. I will say I have done a lot of EMDR
Me
and it
too.
really was profoundly game changing for
It,
me
it
to
is.
overcome some really big barriers. It was originally incepted for Vietnam um, war veterans who had PTSD. And what it involves is there's different ways of doing it, but the
Hmm.
way that a lot of people do it is there's a little bar and your eyes are following this light bar. So they're moving back and forth. And what it does is it stimulates both sides of your brain and it frees you up to have a conversation with your therapist. So you're not just sitting there watching lights all day long. And different therapists do it different ways, but it can calm your nervous system. And I know there's a lot of fantastic vagal nerve specialists out there now that talk about using both sides of your brain and calming your nervous system so that you can actually get to the root of of what's in your way, and that's what that does. So it's just one type, but I know a lot of pelvic health PTs that are working closely with EMDR therapists and getting a lot of great results for their patients as well. So and then there's sex therapists who do a fantastic job of bringing intimacy back into people's lives, and faith-based therapists, if that's really what you're leaning into, that can be assistive for people. There's just so many different types. There's so many different types of people. So having a wide scope of different types of practitioners is really helpful.
Yeah, I do recommend um, a lot of different types of mental health therapies for patients, depending on kind of how they present. I know that the one patient that, when we identified with the imaging example, to go back to her for just a second, we started to immediately talk about what that would mean to identify the root cause of where that was coming from. Because for her, It wasn't like an adverse childhood experience or anything like that, but it came from, turns out, after working with a mental health therapist, she found out pretty quickly it came from unresolved birth trauma.
Mm.
And for her, she didn't have access to, this person didn't have access to EMDR, um, but she had been working with and had a really strong therapeutic relationship with someone who did hypnosis, which I would think you'd have to have a very strong trust, strong therapeutic relationship with them. And in that, it allowed her to, and I think that's the concept of EMDR too, is it just allowed her to finish processing using the full faculties of her mind, finish discussing and talking through the stuck points. That it's kind of like when we try to carry someone through the tendonitis or tendinosis process, and we want to carry them through all the way to healing instead of partial trauma of the tendon, right? And then not finishing the healing process. And so for her, that was a major breakthrough. And I think that if we can, I mean, what we're really talking about is ditching the stigma attached to getting therapy, any type of therapy, but it still exists for mental health, therapy, if we're honest about it. And just straight up saying, gosh, I don't know any woman that could walk through the journey of endometriosis and not need therapy for just what happens as you go through that, mostly because of the delay in diagnosis of 7 to 10 years, and much much longer for other patients. But everybody needs help sometimes.
That's exactly right.
Yeah. Yeah, there's such a heavy psychological impact, of endo. So I think that the way that you see it, just to recap, is just women talking about a tough experience can create pelvic floor tension. What are some of the other patterns that you have seen that either made you stop and take therapy in a different direction for a minute? Maybe it's like a mindfulness practice or some other lifestyle practice, or say, well, and I think a mental health therapist might be a good idea. What are some of the things that you see that are like yellow flags? And you could talk about green flags too, but I think sometimes it's helpful to hear about those yellow flags.
I think looking at day-to-day behaviors and um, comparing it and matching with the patient's presentation on any given day. And I think that speaks to our relationship over time. Sometimes it's apparent, right when you do the eval and you meet them, as to like, let's take exercise for example. Somebody might be quite sedentary, and you start exploring what different types of body movements sound intriguing to them, or that they might be curious about, or which ones they have fear about, and how they're responding to that. And some come in and they're exercising a ton, and we start to see some sort of pattern of flare-up surrounding the intensity of their exercise. And we don't necessarily want to take exercise away and bench
Mm-hmm.
them,
Yeah.
to use that phrase, but just starting to maybe find a mode of exercise and movement that is suitable to the place that they are in now, and then taking into consideration their goals. Taking an example of an avid runner, where they come in and they're running a lot, and we're starting to see flare-ups associated with certain intensities of run or durations of run, and just looking at what would happen if over the next 6 weeks, while we're working in therapy together and we're addressing these other factors, we sticked with the lower intensity run. So you're still getting what brings you joy, and you're still feeling healthy and making your good daily activities that bring you psychological well-being and physical well-being. But we're not going to do that high intensity, or taking somebody again who's sedentary because they are in a lot of pain and really crunched up, and exploring what works well for them. And along those lines, interesting flags that might come up. I had a patient who had a lot of pain, and she knew from listening to other people that perhaps yoga was recommended. And she went to the yoga class, and she said, being quiet and in a quiet room and going through that hour really made me feel anxious and
Mm,
worse because that environment just isn't suitable to my personality type.
yeah.
So I need to do something different. So just gauging it based off of what you're hearing and what maybe they have um, preconceived fears about.
Hmm. Yeah. I mean, I had a patient recently who had a pretty major bowel resection, and so they were going to do a reversal of the colostomy, and that brings up a lot. So if you're out there, you're listening, and you've had bowel endometriosis, which a lot of women end up with bowel endometriosis, you feel like you're starting over with
Yeah.
all your lifestyle choices, with everything that can I eat this now, right? If they couldn't eat it before and it was a huge trigger, you might be able to go back and eat those things now, right? Or how much activity am I going to be able to do? When am I going to be able to do it? All those things can be worked out in the context of a pelvic floor PT who really specializes in the orthopedics, the lifestyle, and of course obviously the pelvic piece. But I'm sure, Amanda, you see too a lot of orthopedic overlap where it's super helpful to have the ortho and the pelvic piece of those puzzles together so that you don't have to have redundancy in PT.
Absolutely. I lean into my orthopedic skills daily. And with every patient, I check feet on every patient because of the relationship between the foot and the pelvic floor, both with common nerve origins and in how we walk.
Mm-hmm.
And yeah, every patients are interested when I'm assessing feet. Did you roll this ankle? Did you ever have a fracture here? Yes. How do you know? I can tell. And it can
Yeah,
change the way they move. So
yeah,
really important.
it is. I think that it's probably it might be important for you as the listener to hear that what does a good endo expert in PT look like, and I think this is where we start to lean into the physical therapist side because ortho PTs are pretty uniquely situated when you've done ortho first and then you came into pelvic PT because you have both of those things. And I do think that's part of a well-rounded program. Not that someone couldn't get away with just like pelvic OT or a pelvic PT who doesn't have any ortho experience, but it does make it harder. I think that person would need to know their limitations, that oh well, I'm not well versed in evaluating feet and knees and shoulders and the cervical spine, but hopefully they know someone who is and can fill that gap.
Yeah.
First of all, I want to thank you for listening. We've had so many downloads and so much incredible feedback. So thank you. And now I have an ask. If you could, and you found this work valuable in the endometriosis and pelvic pain space, in the ending medical gaslighting for women's and pelvic health space, if you could do one of two things, I would be so grateful. One is to leave us a 5-star review. The link is in the show notes, or you can just simply open up your app. And for example, if it's Apple, just go to the upper right-hand corner and click the plus sign to subscribe. 2, if your finances allow for it, could you please consider making a contribution? We don't receive any funding and haven't the entire time to create this podcast. So all of the production costs are coming out of my pocket. We aren't making anything on this at all. It's costing. So every bit of support that you can lend will make a massive difference. Thank you in advance for being a part of this work. Whether or not you've been a guest on the podcast or a listener, or you've downloaded episodes or subscribed and shared, I appreciate it. So if you could leave a 5-star review and consider making a contribution, it would really help the work continue. Thank you.
So let's talk a little bit about um, advocacy, about education. If you know anything about endo, you guys, you'll know that the diagnosis is plagued with late diagnoses and a boatload, a ton, a crap ton of medical gaslighting.
Yeah.
And throughout this entire season, we have talked to advocates and surgeons and other therapists who have talked about how they empower patients to advocate for themselves. If you haven't listened to some of the surgeons, episodes, go back and listen to some of the surgical episodes, because they have unique challenges. Like, what if when they do surgery, we're talking expert excision surgery, that the patient goes back to their home state or their home practice or whatever, and their GYN no longer wants to see them. They refuse to see them because they've seen someone else, right? Which is, I'm just holding my head, right now going, how could someone refuse care because they went out of state to get expert care somewhere else? That's a special kind of closed-minded person who will not see them, but it's happening, right? So, Amanda, and from what you have seen, what are some of those stories and experiences that you've heard patients have, and what have you done to kind of get them past that? I know sometimes it's a matter of talking to the patient and saying, well, maybe a quiet quit is in order of that provider if they're not willing to listen. But what are some of the things that you've been faced with? How have you handled those?
My biggest concern at this moment is the gap in time it takes to get the diagnosis and the amount of advocacy, the self-advocacy and searching for solutions that happens to get the diagnosis. And then the continued advocacy and emotional load and time load that it takes in the living with post-diagnosis and post-operatively, because I think there's a relief in the determination and the label and the diagnosis, and then it's the not all surgeons are created equal. Like you just said, we have expert excisions and we've got 20 ablations a day providers.
Right. You've got people that hang their shingle without, anyone can hang a shingle and say they're an endo expert.
Yep. Yeah, which is I think our current hill that we're all on. Yeah. And forming these lists, and I think I love the concept of provider lists that have been screened by people not in the medical community. So the advocacy driven lists of where people have gone and gotten good care both on the actual surgical side and the humanistic side. And there's a lot of fantastic providers out there that have both, and there's some that have one and not the other, unfortunately. And then it's the living with it, as you mentioned, and the egotistical response to not providing care for a patient. Let's put it into cancer. If a patient were to go from say a state and go to Mayo Clinic and receive some diagnostic workup and some care at a Mayo Clinic and come back, I've not yet been made aware of a primary care provider or a oncological provider that would not care for that patient because they went to Mayo. And Mayo is one of the gold standards of oncological care in this country. We need to get there with endo. And endo is a similar disease. It requires additional education and care. And I would say, if you're in that position, if you've been let go or released by your provider, initial steps would be to maybe get somebody on telehealth in your state. So somebody that can provide telehealth services to maintain you or provide your care. And then finding somebody in your town who can at least do your ongoing pap smear care, because we have two different things. We have what needs to happen annually to continue to screen just as a byproduct of being a woman. And then we have the person that's going to be, providing management with prescriptions and whatnot too. So there's a lot of different ways now to wrap that present that just can require some creativity, but you are worth it and you deserve it. And I don't have the answer of how it gets better right in this moment, but I would say you just got to make it work for the position that you're in at this moment.
Yeah, I think realizing that it will have to happen, that you're going to probably experience these roadblocks because your example was brilliant. That cancer example of if someone went to MD Anderson or Mayo, okay, no one is turning them. Duke is not turning them away when they come home. I'm in North Carolina, so I'm just using Duke University as an example, but they're not turning them away. And yet it's happening because it's women's health and there's not enough awareness with endo. It's absolutely insane. It's wrong and it shouldn't be happening. But instead of saying, oh, well, I guess there's nothing we can do about it then. Well, there is the solidarity that that you have now just in listening to the podcast, right? And knowing that you can reach out and there are providers across the country that we can help put you in touch with. There are multiple lists that can be helpful in seeking out that care. A lot of providers actually are licensed in other states, and so they can provide care across state lines. You'd be amazed at what can be done on telehealth, right? You would think pelvic health PT on telehealth? Yes.
Yep.
Thanks to Intimate Rose and a lot of the tools too, it makes it possible because you can explain concepts. And then as a patient, you go away, you try those concepts, you come back and you go, okay, that worked. Or was that right? Because it felt a little weird when I went in this direction, with a bond or something like that. So there's a lot of stuff that can be done. It is not going to be made right immediately. And I wish we could predict, but looking ahead, it could be 5, 10, 15, 20 years, given the current political climate that we're living in right now, to kind of see women's health finally come around to being a fully respected part of living as a human being on this planet. And I think that all the discussion too about, gynecology can get really negative really quickly because of the burden that they're placed under. Like if you have a heart problem, you're going to see a cardiologist, but then the cardiothoracic surgeon is going to take over and do surgery. Not with women's health. It could be a pediatric problem, gynecology problem. It could be a pediatric oncology It could be menopause. It could be prenatal, postpartum, infertility. Our healthcare system doesn't value women's health enough, because if it did, we would have separate specialties for all of these things. We would have GYN, that would be, menopause. We would have a separate surgeon for it. But they're heaping all this onto, OBGYN's heads and expecting them to just be
all the things.
Yeah, be all the things to all the women, which is absolutely impossible. And I think that if we begin to shift our mindset about it, I know you and I already have, so we're kind of preaching to the choir, talking back and forth. But to the listener, if we can shift our mindset about it and realize that, yep, your GYN is probably not going to know unless they're on the NAMS list, the North American Menopause Society list. If you're going through endo and meno, they're probably not going to know anything about endometriosis or menopause. Hate to break it to you. So you'd have to go to North American Menopause Society and look up that list. But then you're also going to have to look up some of the endo lists, and they're usually not going to overlap.
Right.
People that know about endo are not going to know about meno. And so that is where, that's why I'm doing a whole season on this, on endometriosis. It's why we keep talking about it. It's why I also want to impress upon the listener that pelvic floor PT can do a lot for both, for helping you manage perimenopause, menopause, and endometriosis. So that kind of pushes us into the looking ahead. Like if we're looking ahead, like what breakthroughs, changes, like what do you see, Amanda, that can be in the field of just pelvic health and endo, like within the next 5 or 10 years? What are you hopeful for?
It's going to sound bananas, and I understand this. I've taken multiple meetings in the last few months with different medical tech, provider-driven uses of AI and imaging together to start to get perhaps some earlier diagnostic capabilities in the endo space specific to endometriosis. And the fact that there's multiple,
yeah,
me being a a pelvic health physical therapist and really operating at tissue level, musculoskeletal tissue level, with growing knowledge of technology and AI, but certainly not. I'm not an expert, but when I'm looking at these new entities and I'm listening, and they are driven by these tech people and these providers have endo, their daughters have endo, like they are pushing in the right direction, what I feel is the right direction. I'm very excited about that. And I do think that this landscape and this conversation is going to look really different in 10 years, because I do think something has lit fire in the last 4 years or so. The other side of it is lobbying and looking at policy change around financing research in all those different avenues that you just said. So ensuring that there's adequate funding for research in what happens to a person with endo when they go through menopause. How do those things change? Because this is an expensive problem, and it's pulling people out of school. It's pulling people out of education and their work. It's affecting their home lives. It's affecting relationships, and it's affecting fertility. So my hope and my dream would be that there would be changes in how allocation of funds is made in women's health, and to getting better at supporting this population for all of the reasons that we just described. So those aren't necessarily specific to, and I feel like as pelvic PTs, we're always just going to be the ones that are in the canoe paddling with the patient anyway. So it's like, yay, new AI diagnostic. We're going to get you in faster. You have pain. This is what it sounds like. Boom, quarterback them in instead of what it is.
Yeah, because right now, endo is essentially the way you're describing it. The words that came into my mind was, gosh, endo is a real home wrecker,
Yeah.
It's a job wrecker, it's a life wrecker, but, a home wrecker, when you think of your home being your place of sanctuary and quiet and peace and tranquility, when you have endo, you don't have a sanctuary. Like your own body feels like it has betrayed you. And I mean, that's worth a pause, because it does invade every area of your life. And I think that, as women, you can easily gaslight yourself and say, suck it up, buck up, get over it, push through, because, essentially that's what you were told, especially if you started out and your very first period was painful or awful or whatever. You were always told that because it was overlooked. And if you think about a similar statistic, I think it's probably underdiagnosed at 1 out of every 10, 1 out of every 10 women. Well, if it takes a decade to be diagnosed, approximately, 7 to 10 years or so, we probably have a lot more cases than just 1 out of 10. But if you look at men, 1 out of 10 men are going to have diabetes, and look at the body of research done on diabetes, or the amount of money that's given to Crohn's disease, which I think is like $130 a patient, $130 a patient versus $2 for endo, right? That what you're saying, Amanda, is so important and so true, that we have to have more funding and we have to have the policy to support it. And when you compare it against diseases processes that men would have, there's no comparison. Like, it's virtually ignored. So we want to end on the uplifting positive. We've dispelled a lot of misconceptions and myths. We have talked about the multidisciplinary aspect of care. We have talked about where care needs to go. We've talked about the different aspects of what pelvic PT can do, which is more than just, your internal check of the pelvic floor. Because if you really think about pelvic floor PT as kind of across the lifespan of having endo provider, you'll see a pelvic PT at every new era, right, of your life. And they should be able to, I love your phrase about kind of being in the canoe with with them the whole way. That person should travel with you, through that journey, because we don't just magically get rid of endo, although excision surgery can do a darn good job, these days. It's only part of it. It's not all of it.
That's right.
Yeah. So what suggestions would you have for women with endo who are experiencing, just the frustration, the fatigue, at finding the providers that they want, or feeling like they're not being listened to? What advice do you have for them?
Don't give up, first and foremost. What you deserve and what you need exists. And be checking, if I can say them, Nancy's Nook
Yeah,
and
say
some of
them.
the other End of Endo project that has these lists of vetted providers who have given solid care to other people who are very much like you. We're all unique in our presentation and in our needs from life and from our bodies. But there are providers who are going to listen, and there's already been so much work done to organize them. And then, the Endometriosis Summit has phenomenal providers as well, and education to empower you as well. And then keeping track of different factors of flares and on a calendar, just trying to be as organized as possible with your personal data, so that when you do get to that person, they can easily look at it. And what that might look like is, I've noticed these foods seem to flare me up. I have noticed that in these days after my period, these are my pain symptoms, those kinds of things, so that it's really easy to communicate with your provider, because it is exhausting. So just trying to be as organized as possible with that.
Yeah, I think that's really good advice. And we will put those links that you mentioned, Amanda, in the show notes so that it's easier for you to access them. And I never want to forget, at the end, speaking of links and resources and things like that, where can everyone find you and your products? I know you're on Instagram, so kind of give us a rundown of where they can find you.
Absolutely. On our website, intimaterose.com, you will see the products and the tools, but also what I want to highlight is that under the resources tab, each product has its own guide with lots of different videos to help you. And on our blog, we have now hundreds of different topics and articles to help provide free education, step by step, how to use the wand, how to use the dilators. So our website is a really phenomenal resource. On Instagram, I am at A Olson DPT, and then at Intimate Rose. And I have Substack now, which is Dr. Amanda
Awesome.
Olson, DPT, PRPC. Yeah, I've been loving that, actually. And
Fantastic.
then X. I don't do as much on X, but I am there.
I actually deleted my account.
Did you?
I
I would
did. I
like to do
did.
that. That's a goal I have someday.
Yeah, so yeah, put it out there.
Yeah.
Yeah, sometimes I think about narrowing down, what I do more, because then you can actually focus on your messaging where you are, instead of feeling like you have to cover all the bases. And of course, we're, referring to platforms that don't necessarily uh, vibe with our core values.
Right.
Obviously, if it doesn't vibe with our core values, we're not going to be on that platform.
Yeah.
So, fortunately, there are many different places that you can find Dr. Amanda Olson and all of her amazing stuff. And I love that you have all the resource, the guides, the blog, the videos. It's just amazing. And when I think back to 20 years ago, I'm like, wow, we have come a long way, even though 20 years seems like 5 minutes ago, lots has improved and lots has changed. And so we're just so glad that you're here today and doing what you do and persisting and sharing your story. So thank you so much.
Thank you so much. I appreciate everything that you do.